Okay, so thanks everyone, and apologies for the late start and the confusion about Zoom. There's always a little bit of a confusion, isn't there? So it's a pleasure to introduce our speakers today. We have Monica Carner, Christopher Lord, radiologist from Imperial, and Dylan Griffiths, who is our surgeon from Imperial, and they're going to be talking about the shoulder and elbow and covering elective and trauma surgery. So thank you very much, both of you. Start with Chris.
Okay, brilliant. Okay, so thanks very much for the introduction, and thanks for having me speak today. So I'd like to talk about shoulder metalwork this afternoon. Before I start, I'd like to say thanks to Dylan Griffiths, who's on the call and a consultant upper limb surgeon here at Imperial, and Neeraj Purohit, who's an MSK radiologist down in Southampton, for providing cases for this talk. So the outline for today, so we're going to go through the main types of metalwork found in and around the shoulder and the principal indications for their placement, so covering both the trauma and elective settings. We're going to go through proximal humeral fractures, shoulder arthroplasty, fixation of anterior instability, so Bankart and labral repairs, and then towards the end, have a look at scapular ACJ fixation and also soft tissue repair. As I go through, I'll go through some of the common complications that we find in association with these types of metalwork. This talk will be principally focused on plain film, but also we'll look at some CT and SPECT CT images. So starting off with proximal humeral fractures. So these are very common injuries and are typically found in elderly patients, so a fragility type fracture, and they can be classified according to the NEAR system, which is depicted here. And I'm not going to go through it in its entirety, but broadly speaking, you can classify these fractures in terms of 4 parts. So comprising of the anatomic head, the greater tuberosity, a lesser tuberosity metaphyseal fragment, and then also the humeral shaft fragment. And there's a lot of debate as to how best to manage these fractures, but broadly speaking, the lower grade fractures without significant displacement can be managed conservatively, whilst higher grade multi-part fractures with significant displacement are unlikely to achieve osteosynthesis, so therefore require some sort of surgical fixation. And one of the ways you can do this is by a proximal humeral plate or intramedullary nail. And in cases where there's a high risk of avascular necrosis of the humeral head, intra-articular fractures, sometimes hemiarthroplasty is performed. So this is an example of a proximal humeral locking plate, or otherwise known as the Phylos system. And the indications for this really are multi-part fractures or fracture dislocations, but where there's not a substantially significant risk of avascular necrosis. And often the humeral head needs to be intact when you employ this method. So this is an example here where you've got a comminuted 3-part anterior fracture dislocation. You can see widely separated but intact humeral head fragment impacted on the anterior glenoid rim. And you can see a nice fixation here with a Phylos plate. So you can see anatomic reduction of the fracture fragments. And although this X-ray was taken shortly after fixation, you would imagine that this would go on to successful union and osteosynthesis. So some of the things that can go wrong with Phylos plates. So the most common complication really is screw perforation or screw cutout. And it's reported in up to 60% of these fixations. And this can be either primary or secondary. So the screw perforation is really where the screws erode through the cortex. And this is particularly a problem when they go into the glenohumeral articulation. So this is an example here on the top. So you have a fixation of a proximal humeral fracture, and you can see subtle erosion of this inframedial humeral screw through the medial cortex. And on the subsequent CT image, you can see it protrude through the cortex into the joint. And you can also see glenoid wear in association with this. So you can see irregularity of the subchondral bone plate and sclerosis compatible with degenerate change. And it's important to pick this up early on so that you can either revise or remove the metalwork. So in the secondary instance, a lot of orthopedic literature has focused on fixing what's called the medial calcar, which is this strut of bone which follows the medial humeral metadiaphysis and medial humeral head. And the most important screw in this fixation really is the kickstand screw, which is this inframedial screw highlighted in gray. And this is an example here taken from this paper by Burke and others, in this example, they didn't place this screw, and this is what happens. So you tend to get various rotation of the humeral head as it unites, and you can see that as it rotates round, it starts to collapse in on the medial calcar, and you get screw protrusion or cutout of all these screws, and this will require revision. So another common complication is avascular necrosis, reported in up to 68% of fractures, and this is particularly found in high-grade fractures where blood supply to the humeral head is disrupted at the time of injury. And this is an example here. So you can see this is a multi-part fracture fixed with a phylos plate, which looks satisfactory on post-operative imaging. However, gradually you can start to see irregularity of the humeral articular surface, subchondral sclerosis in keeping with AVN, and then it progresses to frank articular surface collapse and fragmentation.
Chris, with relevance to this, the thing we look most at is predictors of humeral head ischemia. Was a paper by Ralph Hurtle, and so when reporting the initial ones, really the things that are very relevant to me are the metaphyseal attachment to the head. So if you look at the anatomical neck on that medial side, how much metaphyseal attachment there is, and if it's more than about 8 millimeters, then that's quite suggestive that that they won't go on to AVN, or less than 8 millimeters that they will. And that was considered a really good predictor of humeral head ischemia. You know, things like displacement, number of parts didn't have huge relevance to it. So that's the one thing. And then loss of the medial hinge. So if you imagine if the head moves laterally on the shaft and the soft tissue hinge is lost, then that's another sort of predictor of humeral head ischemia. That's quite a good predictor, if you like.
I've actually got a diagram of that at the end. I can share.
Perfect.
Let me just show you that.
Yeah, that's perfect. Yeah.
So this is what Dylan's talking about. So this is the metaphyseal extension. So this is the metaphyseal component of the humeral head. And if it's less than 8 millimeters, it's predictive of disruption of the blood supply. And this is the periosteal hinge here. So, it's this sleeve of periosteum on the inner margin of the metaphyseal region. And if that's disrupted again, that's predictive of AVN. So, sorry, just going back. Sorry. One of the other complications potentially of phylos plate is non-union, and you can see this is a classic example of radiographic non-union here. And you can see, so this was a spiral fracture of the surgical neck and clear features of non-union. So you've got a widely separated fracture cleft, subchondral sclerosis without bone trabeculation across the margin, hypertrophic non-union at the medial calcar, and you can also see that these screws are loose here. So you can, I don't know if you can, it projects very well, but you can see a rim of periprosthetic lucency around the screws in keeping with loosening. And this really happens in up to 13% of these fractures. So another form of fixation is intramedullary nailing, and historically intramedullary nails were indicated for fractures of the shaft, but as the metalwork has improved, they're now also used to fix proximal humeral fractures involving the head and even multi-part fractures. So this is a very nice example of that. So you have a 4-part fracture here with valgus angulation of the humeral shaft, and you can see that it's been fixed with an antegrade short humeral nail, and this is a really good result. So you can see anatomic realignment of the fracture parts. You can see medullary bone continuity in keeping with osteosynthesis, and overall a good result. The other thing to consider with intramedullary nail is it's the primary fixation method for pathological fractures. So this is an example here where you have a lytic, ill-defined lesion within the humeral neck, which was a myeloma deposit, I believe, with a pathological fracture. And you can see a long antegrade intramedullary nail across that fracture site. And overall, the complications associated with nails are similar to those associated with plates. So things like screw cutout, non-union, and loosening. But I think overall, there's been a recent RCT showing that plate fixation has less complications overall in comparison when you look at the long-term outcomes. So I don't know if that's right, Dylan, but for these fractures,
I'm not sure in proximal humerus fractures. It's such a nobody's got a fixed idea. Everyone has their own algorithm, which is part of the problem. I tend to use nails for two-part fractures, and I think it's a very good way, based on my own experience, that I don't think Phylos plates do well in the elderly, and that was what they were designed for. They were locking plates for the elderly. I think all that happens is you get fixation distally, fixation where the bone is better distally, and then that head just moves around the raft of screws. And it was one of the things, another paper from Ralph Hurtle, where he says it's not a good environment for healing. And I think a lot of the time when it may be reported as being healed, actually the fractures aren't fully healed. I think they take a long time to heal. Whereas I think union is far better, and I think external rotation is far better with the nail. But there will be people who disagree with that, and you know, the what is best is not clear. There's no doubt about that.
Okay. Thank you. Okay, so moving on. So hemiarthroplasty. So this is where you replace the humeral side of the joint with a prosthesis. And the indications are really for humeral-sided pathology. So as we've already mentioned, comminuted intra-articular fractures splitting the head, which are likely to progress to AVN, and also humeral-sided arthritis. And in these situations, it's preferable that you have an intact rotator cuff and relative absence of glenoid wear. However, there is a circumstance in the end stage, you know, in a very degenerate shoulder, where you can't cite a total shoulder arthroplasty, where you can put a hemi in as a sort of salvage procedure. This is an example here of a comminuted head-splitting fracture of the proximal humerus, treated with a cemented and stemmed hemiarthroplasty. And the hemiarthroplasties can also be stemless, as in this example down here. And the benefit of this is that it facilitates revision later down the line. So you can also have resurfacing hemiarthroplasties. So these are indicated for less severe pathology on the humeral side. For example, less severe arthritis, AVN, large osteochondral lesions, or Hill-Sachs lesions. And the benefit of this, of resurfacing hemiarthroplasty, is that you preserve the native anatomy of the humerus, and you also preserve the bone stock, because when you put these in, you don't need to do an osteotomy. You just ream the humerus and then resurface it with a metal alloy cap, as in this situation. And by preserving the native anatomy, you preserve a lot of the function, and by preserving the bone stock, you facilitate future revision if required. So one of the most common complications and related to hemiarthroplasty is glenoid wear. And this is where you get unopposed wear from the humeral prosthesis on the native glenoid. And this often precipitates failure and necessitates revision of the prosthesis. So this is an example here of a resurfacing hemiarthroplasty with satisfactory appearances initially post-op. But over a period of 6 years, you can see cranial migration of the prosthesis, and you can also see glenoid wear here. So you can see remodeling of the glenoid and features of degenerate change with osteophytosis and subchondral sclerosis. And the shoulder was increasingly painful. So when we went to SPECT CT, you can see radio tracer uptake at the posterior superior margin of the glenoid indicating wear, and you can also see radio tracer uptake with cranial migration of the prosthesis impacting on the undersurface of the acromion, indicating wear at this site, and also the presence of a rotator cuff tear that's developed in the interim, and this was subsequently revised. So moving on to total shoulder arthroplasty, so there are a number of important...
Chris, sorry, just on that.
Yeah.
That's a Copeland hemiarthroplasty. There used to be loads of them out there. There'll be progressively less and less. If you see a half shoulder replacement done at our place, it'll be a ceramic head because the wear properties are less. Even on the glenoid, even if you haven't got a socket, the wear properties are still less. So there's that's quite an outdated prosthesis, and but certainly not at this institution from us.
Okay, that's really helpful. So moving on to total shoulder arthroplasty. So there are a number of important preoperative considerations prior to implantation. And the most important one really is the preoperative morphology of the glenoid, and in particular glenoid retroversion. So this is really the angle of the glenoid face in relation to a line perpendicular to the scapular axis, as shown on this image here. And in the preoperative situation, we often measure this at mid-glenoid level, just below the coracoid tip. And any excessive retroversion, so posterior angulation of the glenoid face, is important to flag up to the surgeons, because if it's not identified preoperatively and you place a glenoid component in a retroverted glenoid, it predisposes it to early failure and posterior instability. And the value is sort of less than 10 is okay, but roughly anything above 10 will require some sort of surgical intervention. So whether that be eccentric reaming of the glenoid or glenoid augmentation at the time of surgery. The other important measurement is glenoid bone stock, illustrated in this diagram here. And so that's really the quantity of bone of the glenoid measured between the articular surface of the glenoid and the scapular neck. And that should, it's a ballpark figure, but that should really be above 20 millimeters. And having sufficient bone stock there facilitates implantation of the glenoid component. And if you don't have enough bone stock, you may need to augment the glenoid with bone graft material, or you may need to use a special prosthesis when it comes to arthroplasty. So this is the Walsh classification of glenoid morphology, and we use this preoperatively to describe the shape of the glenoid. And there are two main types of glenoid wear that happen in arthritis. So you can either have concentric wear, where the wear happens in the center of the glenoid, leading to saucerization of the glenoid fossa. And you can see this in inflammatory arthritides. Or you can have posterior wear, which is the B-type glenoids, where you get posterior wear on the posterior glenoid rim and eventual development of a biconcave glenoid, as in the B2 format, which is where you have a biconcave shape. And the C-type glenoid is really an excessively retroverted glenoid greater than about 25 degrees. So in anatomic total shoulder arthroplasty, you tend to have a polyethylene glenoid component and a humeral replacement, which is similar to the hemiarthroplasty. And the main indications for this is arthritis on both sides of the joint, avascular necrosis with secondary degenerative arthritis, or you can use these to revise hemiarthroplasties that have failed. There are a couple of key requirements, one I've already mentioned, which is the glenoid morphology, suitable glenoid morphology, but also you require an intact rotator cuff for this. So we will often check the integrity of the rotator cuff prior to implantation of a total shoulder arthroplasty. So these are a couple of examples here. So this is one with an osteoarthritic shoulder. You can see treated with a total shoulder arthroplasty with a stem. And you can see satisfactory alignment. The humeral prosthesis is center within the humeral shaft, and the glenoid component is, the humeral component is center within the glenoid fossa. This is another example of a total shoulder arthroplasty for avascular necrosis. So you can see collapse of the humeral articular surface and degenerative changes on the glenoid side, treated with a stemless TSA in this case here.
Just on that, those little dots, that was part of a study. These are RSA beads that are being used to monitor the prosthesis, and particularly the glenoid, but loosening of the prosthesis. And that's why you got all those little white dots on that. And this is the hemiarthroplasty that we use here as a stemless hemiarthroplasty.
So the commonest complication of total shoulder arthroplasty is rotator cuff tear. It's one of the common complications. And in particular, the subscapularis tendon tends to fail. So this is an example here of an anteriorly dislocated, so this is an axial view showing an anteriorly dislocated humeral component related to complete subscapularis tear. This is an example here. I think this is the earlier case actually. So this is an example of supraspinatus failure. So you can see normal alignment of the TSA in this radiograph, but over time you can see cranial migration of the humeral prosthesis, which starts to articulate with the undersurface of the acromion, compatible with supraspinatus failure. And this is an important complication because it also leads to loosening on the glenoid side, because as the humeral component tends to migrate, it tends to cause what's called a rocking horse phenomenon on the glenoid, where it starts to rock the glenoid component, predisposing to failure. And the other common complication, which is the other common complication in TSA, up to 39%. And loosening in total shoulder arthroplasty tends to happen on the glenoid side. And the radiographic features are really a continuous radiolucency, and in the literature they state it's greater than 1.5 millimeters at the interface between the prosthetic and the bone. So this is an example here. So you can see this rim of periprosthetic lucency around the prosthesis, and you can again see that on the axial CT image. You can see this rim of periprosthetic lucency around the prosthesis. This is another example here. It's a bit more difficult to see on this frontal radiograph, but you can see there is some radiolucency tracking deep to the polyethylene prosthesis here. And when we did a SPECT CT, you could show it showed radiotracer uptake at the interface, suggestive of healing. So moving on to reverse total shoulder arthroplasty. So this is where you reverse the geometry of the shoulder joint. So you have the ball on the glenoid side and the socket on the humeral side. And the main indications for this are really end-stage arthritis with rotator cuff deficiency, or complex fractures in the elderly or those with osteoporotic bone. And the benefit of this is really that you realign the geometry of the shoulder. So you medially and inferiorly migrate the center of rotation. And what this does is that it restores tension on the deltoid and allows and sort of augments deltoid function. So this is the sort of schematic showing the constituent parts. So you have the metal glean component, which attaches to the glenoid, the glenosphere here, and then you usually have a polyethylene spacer in between the glenosphere and the humeral component, which has a humeral cup to articulate with the polyethylene spacer. This is an example here that we did. So this is, you can see there's evidence of a clear rotator cuff arthropathy. So you have cranial migration of the humerus with fragmentation of the undersurface of the acromion and some secondary degenerative changes in the shoulder joint. You can see this is implantation of a reverse total shoulder arthroplasty. And you can see that the humeral cup articulates with the glenosphere, and the glenosphere should really be put in at neutral version and inclination.
Just on that, just going back, It is very worth reporting here that the fragmentation of the acromion that you can see, which, because acromial fractures is one of the complications of reverse shoulder arthroplasty. So actually, an ossacromianale or fragmentation of the acromion are quite relevant. There is evidence suggesting you can still do a reverse, but it's very relevant. And the other thing is just how high this has gone, because the relevance to us is that then we're bringing him down, because we're bringing him to the bottom of the socket, bring him down about 3 or 4 centimeters, which may be beyond what your brachial plexus can tolerate, is the other thing.
So this is another example of a reverse TSA done with glenoid bone graft, or augmentation of the glenoid. So you can see here on the preoperative image, this is a very deep concentric glenoid wear here with saucerization. You can see how thin the glenoid fossa has become, and you can also appreciate how little bone stock there is. So you wouldn't be able to get away with a standard implantation, because it just wouldn't hold. You wouldn't have the purchase. So this is where we use bone graft to augment the glenoid, and you can't see it really on this frontal image, but you can just about make it out on this axial image. So you can see the margin of the native glenoid here, so deep saucerization of the glenoid, and you can see bone graft material along the length of the metal glean screws going between the native glenoid and the glenosphere.
This was a rheumatoid lady with where we did a huge bone graft on there. It's an angled bone graft to correct her version. I think the view on the left, it looks in essence too severe, because at the bottom of the glenoid you do have some bone, yeah, I mean she's rheumatoid, hence why we've cemented the stem. Her bone wouldn't have been good quality for a short stem, which you might see in others. But it's all about trying to correct that inclination, that version, and fill in effect what was a massive posterolateral defect in her glenoid. Hopefully this bone will then integrate with her own.
So dislocation is one of the more common early postoperative complications of reverse shoulder arthroplasty. And it's seen in up to 20% of cases. So this is an example here. So you have the normally aligned reverse shoulder arthroplasty, and this is an instance of dislocation, and almost always the dislocation is anterosuperior. So you can see the humeral cup no longer articulates with the glenosphere, and the humerus is migrated superiorly and anteriorly towards the coracoid. And this can happen with relatively innocuous history, and it relates to really the unopposed action of the deltoid as the rotator cuff is absent. Do you have any comments about that one, Dylan?
To my mind, there's generally something wrong within the operation if your shoulders, if your reverse is dislocated. I've had 3 dislocations in around 120, I think. And one was, I found that we had a problem cementing the stem. It was a fracture one. We had a problem cementing the stem, and no cement in effect went down the canal at all. And so the whole thing was just twiddling around when we revised it. Another one was using a new prosthesis where, to be honest, it was probably my own surgeon error that meant it dislocated, and we revised it by altering those components. But it was done for a chronic dislocation, so the risks are higher there. And there was one other, I can't remember the details, but yeah. So I to be honest, unless they've got a funny movement disorder or there's something else strange going on, really, these glenospheres are quite big. So I personally don't think these should be dislocating at that rate at all.
Okay. So this is another complication. So loosening of the prosthesis, similar to the anatomic total shoulder arthroplasties tends to happen on the glenoid side. So this is an example here where you can see on this AP radiograph that there's continuous periprosthetic lucency with some sclerosis related to the metal glean peg. And you can see on the SPECT CT image that that corresponds to intense radiotracer uptake at that region, supportive of loosening. A complication that's specific to the reverse shoulder arthroplasties is scapular notching, and in the literature this is reported happens in up to 50% of cases, and this is where you get focal osteolysis, typically at the inferior margin of the glenoid and scapular neck, related to impingement from the humeral cup. And you can see this is an example of that. So you have this lucency related to the inferior metal glean screw. And the problem with this is that it predisposes to failure of the prosthesis on the glenoid side. Less frequently, this can happen posteriorly as well. So this is another example of scapular notching, but on this axial view, you can see it's happening at the back of the glenoid. So you have osteolysis related to the posterior screw in this instance. So humeral loosening applies to all shoulder arthroplasty, but it's relatively uncommon, so less than 1% quoted in the literature. And again, it's characterized by circumferential continuous radiolucency related to the humeral prosthesis. The other features are that you might start to get tilting of the humeral prosthesis as you start to erode the endosteal bone and as it starts to move. And you may also see subsidence where the humeral prosthesis sinks into the humeral shaft. So this is an example here where you can see on this radiograph continuous periprosthetic lucency here, and on the CT image you see that more clearly, but also you see tilting of the prosthesis as it started to erode the endosteum here. And on the axial view you can see eccentric osteolysis related to the stem and endosteal scalloping and cortical thinning on the lateral margin. So periprosthetic fracture is another complication, and this is, I think, I can't remember what this classification is called, but it's quite an easy one to remember.
Vancouver.
What was that, Dylan?
Vancouver.
Vancouver. So there are three types. So type A is above the level of the humeral prosthesis, type B is at the level of the tip, and type C is below the level of the tip. And this is an example here of a hemiarthroplasty with periprosthetic fracture. You can see this spiral fracture arising at the level of the tip, but propagating into the proximal humeral diaphysis, compatible with a type A injury. And you can see these metallic artifacts here are represent the humeral brace. So this was treated non-operatively and conservatively, and you can see osteosynthesis on the interval radiograph down the line. So this was managed conservatively.
Purely what we really want to know there is do you think the prosthesis itself is loose? Because if the prosthesis itself is loose, there's no point in us just fixing the bone. I mean, this they're very lucky that healed, to be honest. In most cases, you would fix that. You'd fix the fracture, but that is no good if your prosthesis itself is loose because of the fracture. So that's your decision making, really.
So just briefly to touch on infection. So this is characterized by rapidly progressive irregular periprosthetic lucency, which you can see on serial plane imaging. You may also see osteolysis, periostitis, and soft tissue swelling. So this is an example here. Unfortunately, it's not projected very well, but you can see irregular periprosthetic lucency related to the humeral hemiarthroplasty. There's also periosteal reaction on the medial cortex and some osteolysis at the top of the prosthesis. This is, you may also see this kind of situation where this is where the humeral prosthesis has been removed, and they put in a cement spacer into the defect, which is impregnated with antibiotics and held in place with a wire. And this is really to treat chronic infection. In equivocal cases, SPECT-CT can be, dynamic SPECT-CT can be really useful. And also you can use indium labeled radiotracer, so white cell imaging, to confirm infection as well. So moving on to anterior instability. So I'm sure you're all very familiar with this. So the characteristic injury pattern as the humeral head comes out of joint is the Hill-Sachs lesion at the posterolateral aspect of the humeral head. And you get a variable injury as the humerus impacts on the anterior glenoid, a variable injury occurring at the anterior-inferior quadrant. So this can either be osseous, so the bony Bankart as shown in this situation, where you have a large osseous defect and a displaced anterior-inferior rim fragment, or it can be a soft tissue Bankart. So this is an example shown on this MR arthrogram in the axial plane of a soft tissue Bankart lesion. So this is actually an anterior periosteal sleeve avulsion, where you can see a contrast cleft extending through the base of the labrum, medialization of the labrum, and periosteal stripping. But the important feature of this is that there's no significant osseous component and there's no cartilage loss. So these two injuries are treated very differently. So in the soft tissue lesion, often these are treated with a Bankart repair, which is shown in this schematic, which is where you reattach the torn labrum, scapular periosteum, and labra ligamentous complex to the anteroinferior quadrant of the labrum. And this can be either done with bioabsorbable anchors or non-absorbable anchors. So this is an example here where you can see non-absorbable anchors situated at the anteroinferior quadrant of the bony glenoid in keeping with a soft tissue Bankart repair. You can also see some degenerative changes in the shoulder joint. However, when there's a significant or substantial bone loss, we know that Bankart repair tends to fail. In these situations where there's significant bone loss, the procedure of choice would be using a bone block to fill in that osseous defect. And I think this is more of a historic procedure now, but one way that this used to be done was the Latarjet procedure.
Oh no, it's still very much used.
Is it still very much used?
Okay. I don't use it now, but it's still very much used.
Okay, so this is where you excise the coracoid process with the short head of biceps tendon still attached, and you reattach this, or you graft this to the anteroinferior quadrant of the glenoid, and fix it with 2 screws to sort of fill in that bone defect and stabilize the anteroinferior rim.
They think the conjoint tendon that attached gives us a soft tissue sling is one of the theories.
Okay. And so this is an example here where you've got 2 screws in the anteroinferior quadrant, and you can see the bone block here. On this axial image, you can just about make out the coracoid bone block. And this is an example here. It's actually a very nice example where you can see continuity of the glenoid articular surface. You can see that the bone block has restored that anteroinferior margin of the glenoid, and there's osseous union or osteosynthesis between the coracoid fragment and the native glenoid.
This was an epileptic, and this is when a Latarjet goes well. The problems are that it changes the nerve anatomy because the nerve gets dragged with the conjoint tendon. And from a radiologically point of view, it's whether you are actually going to get full union. It's whether you're getting lysis around your screws, which is the problem with the screws. And it's just fraught with problems. And this is a nice one that Chris has got, but there are other ones I've done. In fact, this guy's other side, where there's actually lysis around his screws, and it's gone less well. And that's why I've changed what I do.
And do you mean, sorry, the nerve you're talking about, are you talking about the axillary nerve?
Axillary nerve, yeah. Just
Okay.
because you move the conjoint tendon, they found it just moves the axillary nerve closer to the glenoid rim for further surgery. Because you've got to remember, anybody who keeps dislocating their shoulder, they're on a path to arthritis in the nicest possible way. You might arrest that, but you've got to think about arthroplasty down the line as well. So yeah, they're all kind of relevant things.
So this is an example of a different bone block procedure that I think this is the one you do, isn't it, Dylan?
Yes, yeah.
The iliac crest bone block. And this is essentially an autologous iliac bone transfer. So you graft bone from the iliac crest and implant it on the anterior-inferior quadrant of the glenoid. And this is an example here. So you've got anchors within the anterior-inferior glenoid with, you can just about make out the bone block here. And you can see a nice example here again of the bone block, which is united to the native glenoid and is actually a very anatomic bone transfer here. And essentially, the arguments for doing this, correct me if I'm wrong, are really that because you can take autologous bone from the iliac crest, you can get a more anatomic fixation, and also you preserve function because you don't disrupt the conjoint tendon as you would in the Latarjet.
My biggest reasons for doing it are you don't appear to get the same lysis around screws and the same problems with screws. If you have a problem here, these are little endo buttons. The ones with the multiple dots in them are at the front, and the others are sitting at the back of the socket, connected by sutures, very strong sutures. So it seems to heal well. I do it arthroscopically, so I'm not then having to do a revision approach if they need an arthroplasty or a further operation. And yeah, you haven't got all those issues with the screws, etc. So the metalwork issues. So it appears to be a fairly non-invasive, good way of doing it. Actually, I'm probably going to swap to using the end of their collarbone, because just because the procedure, technically technical iliac crest, and then we operate on people quite sat up when I do arthroscopy, which means that the process is taking too long. It's probably taking too long because I'm a bit slow at it at the moment, because I've not done that many of them yet, but it's also taking too long because of harvesting this graft. I've done one of them with allograft where I didn't feel completely comfortable with it, and I think clavicle is what I'm going to use now.
Okay.
Yeah.
So this is an example of where it can go wrong. So this is a failed Latarjet procedure. So you can see on this frontal radiograph, you can see that the two screws have fractured, and one is actually migrated into the axillary recess, and you can see secondary degenerative changes in the shoulder joint. So on this axial CT image, you can see that the screws, this is the screw here, and this is the washer, I believe, displaced into the axillary recess, and you've got hypertrophic remodeling of the bone block. On this coronal MPR, you can see actually that this is ununited. So you can see a loosened cleft between the bone block and the native glenoid, with cystic change and sclerosis indicating motion across that articulation and non-union.
This is exactly why I have moved from Latarjets. The nerve anatomy is quite daunting, because this would have been third time surgery we were doing, so everything's scarred up. You don't know where your nerve is because it's not in the normal place, and we got one jump of the nerve, quite significant jump of the nerve, because we didn't quite know where it was, and so that's the issue. And this guy's epileptic, had fairly uncontrolled epilepsy when he was younger. It's not the fault of the operations necessarily, but I think this is what can happen with Latarjets, certainly.
So moving on to scapular fractures. So aside from those seen in anterior dislocation, these are relatively uncommon, and we often see them in the context of major trauma. The majority of extra-articular fractures are managed conservatively. So, for example, those affecting the scapular blade, the coracoid, or the acromion can be managed conservatively unless significantly displaced. However, intra-articular fractures, for example, in this case here, you can see an intra-articular fracture extending through the neck and the articular surface of the glenoid with significant displacement. So this sort of fracture would be managed with open reduction internal fixation. Another important scapular fracture is that seen in what we call the floating shoulder, which is where you have a scapular neck fracture and an ipsilateral clavicular fracture, which essentially creates a free floating segment and complete dissociation between the shoulder girdle and the axial skeleton. And that really requires fixation. So this is an example here where you can see that there's a fracture extending through the neck, and there's been plating across the neck with fixation of the glenoid with screws. And you can also see fixation of the ipsilateral clavicular fracture. And this is a maximal intensity projection, again showing the plate fixation at the level of the neck and multiple screws traversing the glenoid and restoring the glenoid anatomy.
I didn't mean it to be that long, that screw, but
which one? This,
yeah,
this
that
one.
one's, it's a bit on the long side, but
so moving on to the ACJ. So often, I mean, the lower grade AC joint injuries can be managed conservatively, and there is some debate about this, but broadly speaking, higher grade Rockwood classification injuries, grades 4 to 6, can be managed operatively. And you'll remember that the problem with AC joint dislocation is both rupture of the acromioclavicular ligaments, but most importantly, the coracoclavicular ligaments. And the goals of reconstruction or fixation of ACJ is really to augment or reconstruct the coracoclavicular ligament. So this is an example on the top of an AC joint reconstruction. So you can see a type 5 dislocation with wide separation here. And in this situation, they've excised the lateral clavicle and reconstructed the coracoclavicular ligaments with a screw in situ within the distal clavicle.
and that would be called a modified Weaver-Dunn reconstruction.
And that's where you use the acromioclavicular ligament.
Coracoacromial ligament. So
No, don't you use the acromioclavicular ligament as well? You can augment it with the acromioclavicular, or not?
well, the acromioclavicular is really just your joint capsule as such. It's the coracoacromial ligament.
Sorry, apologies, coracoacromial.
Yeah. We detach from the front with a sliver of bone and then plug it in to the end of that clavicle.
Yeah.
Which in effect is a reconstruction then, and then whatever modified method you use to support it won't be necessary down the line, because that will hold it.
And then this is an example of an augment, I believe. So this is another grade 5 AC joint separation treated with endobutton. So is this the tightrope system, Dylan, I think?
Yeah, it's a suspensory mechanism. I mean, I do this arthroscopically with a bigger incision up on the top. And the problem, they all have their problems. It's not really solved how to fix these, because they all have their problems. And the problem we have with this is quite a lot of subluxation. So about 50% of these will still sublux to a grade 2. So that's the problem with that. I try to suture the AC joint capsule to support it, so you've got 2-point fixation, and everyone has their various issues. If you're using something called a lockdown, which is a very thick synthetic ligament, the problem they get with that is osteolysis of the coracoid. So everything has its issues, and people have their different choices on how they do it, because nothing's perfect at the moment.
So this is the last topic, so rotator cuff repair. So cuff repairs are indicated in sort of active individuals with substantial cuff tear and preservation of rotator cuff musculature. And typically, these are done with an anchor fixation. So they can either, so this is an example of a subscapularis repair. You can see multiple anchors situated in the lesser tuberosity. And rotator cuff repair can be performed with either using a single row of anchors or a double row of anchors. And although, correct me if I'm wrong, double row anchors are thought to be more secure. That hasn't been borne out in outcome data or clinical data. So at the moment, it's sort of up in the air as to...
They've shown better healing of double row repairs.
Okay.
No functional improvement, no functional difference. The problem is it's such a heterogeneous group. I feel fairly sure that double row repairs will be found to be superior, but it's just getting a comparable group is so difficult.
Okay. So this is an example of anchor migration in a rotator cuff repair. So you can see from this plane radiograph, it's pretty subtle, but you can just about make out that there's a displaced anchor here in the deltoid region. You can also just about make out that the more distal row anchor has started to back out of the greater tuberosity here. And when this went to MR, you can see that there's a displaced anchor here on this coronal T1 image, and you can see that the distal row anchor has started to back out of the bone, and you can also see evidence of a recurrent rotator cuff tear on this coronal fluid sensitive image with a full thickness defect in the supraspinatus. So sort of carefully interrogating the metalwork is key in these cases, as actually it can be quite subtle. So in summary, we've gone through the spectrum of metalwork found around the shoulder, common indications, and we've also been through common complications, and I hope that this talk will help you report these examinations in the future. Thanks very much for listening, and thank you so much, Dylan, for your input.
No problem.
Thank you, everybody. And Chris and Dylan, what an amazing and comprehensive review. Seriously in-depth, and so good, Dylan, to get the surgical insight in particular. We just have one question, which is, what is the change in the modified Weaver done versus the originally described Weaver done?
So the originally described Weaver done took the coracoacromial ligament and put it into the end of the collarbone to hold it, but there was nothing supporting it. So the modified element is basically the mechanism that's used to hold that down. So it could be a screw, it could be one of those suspensory mechanisms that I use, which is how I do them. But it could be anything that holds that down. It could be a hook plate. That's the modified element of it, because basically they found that they were all subluxing.
Okay, great. Thank you very much. So we're getting some fantastic messages from everyone. That was such a superb talk and covered so much ground that I think it would be impossible now to kind of race through the elbow in our kind of remaining 5 minutes. So Dr. Monica Kana has very kindly agreed to do her elbow talk at another session, which we will schedule, everyone. And obviously, Dylan, we're going to have to coordinate with you as well. So don't forget to fill in your feedback forms. Don't forget that you can go onto YouTube.
Could I just say something?
Yeah.
Elizabeth, can I just say something? The one thing we sort of maybe just skipped over a tiny bit was shoulder arthroplasty is sort of divided into your fracture ones and your non-fracture ones, and they have their different problems. If you have a fracture, say hemiarthroplasty, what's really relevant is the tuberosity is often lies. So in effect, what a radiologist may see is they seem to have put bone around in the tuberosity region, and now their head's gone up and I can see no bone there. That's either they've pulled off or they lies. I think they lose their blood supply. And that is the main reason there's been a big push towards reverse arthroplasty for fractures, because then it doesn't matter so much, because the rotator cuff isn't required to provide a fulcrum. It's the prosthesis itself, which is a fixed fulcrum prosthesis that provides that fulcrum for the deltoid to work. And the other thing is with reverse shoulder arthroplasty, we showed a lot of, we showed the socket getting loose. I mean, there was one you showed, Chris, where it looks frankly loose. That there's probably an intraoperative problem, or it's infection. if you've got gross loosening, I think of a reverse glenoid now, because what we're finding with the reverse glenoids, we're getting much better, we're doing much more, is that the sockets are lasting really well, because the socket gets, it's an uncemented socket, it gets concentrically loaded, and it really, I think they're going to really last quite a long time, these sockets. And so then you're almost going to get a change of what used to happen. Shoulders always failed on the socket side, but I think in the next 20 years, you're going to see start seeing shoulders failing more on the humeral side, because the sockets are becoming so good with these reverse concentrically loaded sockets. And so I think you will see a shift in what you're seeing. And I think some of that reported stuff was almost in the playing phase with reverse shoulder arthroplasty, where people just weren't doing enough to get good at it.
Okay, great. Thank you, Dylan. It's invaluable to have that kind of input. Does anyone else have any other comments that they want to make?
I have a question, actually.
Yeah.
Chris and Dylan, thank you so much for those amazing talks. When you were talking about the humeral head fractures, and Chris mentioned about the metaphyseal attachments, are you expecting us to mention that in our report? So how can we identify those metaphyseal attachments?
From my perspective, I think it's just thinking a little bit along the lines that I'm thinking, because that's what I'll be looking for. Actually, I'm not too worried if there's a head split, because actually the predictors of humeral head ischemia were not that a head split necessarily goes on to AVN, but it's that humeral head attachment. Is there a significant humeral head attachment? And I think it's worth a comment. Certainly, the medial hinge is a bit of an implied one, and so I'm not sure that, but certainly the attachment to the anatomic humeral head is quite a useful thing to report, I think, because you may be able to, what you forget is you have all the ways of looking at an image, and sometimes you can look at it far more accurately than we can. And so, you know, I might be struggling away with my recons trying to see if there's decent attachment to the humeral head, whereas you can do that more accurately. So I think it's useful to report.
Thank you.
Okay, great. Thank you very much, everyone. We will let you know the rescheduled dates for the elbow session, and have a good afternoon, everyone. Bye-bye.